Assalamualaikum and good morning to everyone. So my name is Dr. Rajib from the Department of Radiology. So inshallah for today, I will be presenting about introduction to interventional radiology. So now I will be sharing my screen. So can everyone see my screen?
Yes, yes.
Okay. So, okay. So for today, this are the outline of my presentation. So before we go on further, so I think we should understand what is interventional radiology. Interventional radiology is a subspecialty which provides minimally invasive diagnosis or treatment using imaging, for example, ultrasound, CT, or fluoroscopy, to target the intervention and show the result of the intervention. So we can divide interventional radiology into peripheral intervention and also neuro intervention. And as the names goes, okay, neuro intervention means the procedure involve the central nervous system, for example, the brain and also the spinal cord. And for peripheral intervention is the other part of the body. So briefly, how to become an interventional radiology. So first of all, of course, after you finish your medical undergraduate degree, so you need to do 4 years of training to become a radiologist, and then followed by fellowship for about 2 to 3 years. Okay. Okay, so briefly about IR service in SASMED. Okay, so currently IR service is being provided by our radiology department, and we have one IR currently, okay, which is Associate Prof. Dr. Ahmad Razali. Okay, one of our radiologists is currently doing his fellowship training in interventional radiology in hospital UKM. Okay, and some of the other radiologists can do basic interventional procedures, for example, drainages, PICC incision, okay, pump catheter, and some advanced IR procedure we also can do, but then under the supervision of our IR. So we also got other support staff, for example, radiographers and also nurses in the department. Okay. So how do we request the procedures? Okay. So as usual, okay, as all other radiology examination, what we need is the procedure form. Okay, we need to fill the procedure form and also to fill in the consent form, okay, for both procedure consent and also contrast consent. Okay, and so if we want to request, okay, we can either come direct to the department, okay, and directly discuss with our IR or the radiologist in charge of IR of the day. Okay, and this usually we do for complicated cases, for urgent cases, and cases that require discussion. For example, if the clinician is not sure what type of procedure that should be done on the patient, so maybe you can come and discuss with us, and we can suggest what kind of procedure is suitable for that case. Okay, and for non-complicated cases, for normal cases, okay, for non-urgent cases, okay, you can submit the completed request form and consent to radiology department counter, and then later on we will vet the forms and give you suitable dates for the procedure. Okay, so beside that, okay, you also need to provide us with any previous imaging that is available. If the procedure, if the imaging is done in SASMED, there will not be any problem because all the images will be in our system. But then sometime when the patient is referred from other center, we got trouble because all the images is not available in the hospital. So sometimes you might need to trade. So it will be good if you provide us with CD or film so that we can use it, okay, for example, for comparison and to revise the diagnosis, okay, for planning of the procedures and sometimes can even avoid unnecessary repeat of examination. Okay, because this can okay, yeah, you have to consider about the radiation and also the cost to the patient. Okay, and don't forget to write the name and the phone number of the doctor in charge on the request form, because sometimes we might need to contact you to clarify some things about the patient. So on the day of the examination, okay, the cases will be called to the radiology department, to our angel suite, okay, as scheduled, okay. And then for urgent cases, usually we will call the case stat, okay. When we accept, we will ask the referring team to bring the patient down straight away. But then sometimes we got issue, not sometimes, but quite frequent, okay, we got issue with the ward. Patient take too long to reach the department. Okay, sometimes can be up to 2 hours. Okay, so this can cause delay lah, both on our side and also on the managing team side. Okay. So if there is any what from the staff from the ward, maybe you can like take some thought lah into this. Okay, for the procedures, okay, patient preparation, okay, the preparation is similar to other surgical procedure. Okay, so you need to fast the patient. Okay, IV lines, suitable IV lines need to be on the patient, okay, to be used for resuscitation, for infusion, for sedation. Okay, and then for some procedures, for example, um, angiography, okay, we usually will puncture at the inguinal area. We will target the common femoral artery. So the ward team might need to like shave and clean the inguinal region, okay, so that it will be easier and be cleaner for us to do the procedure. And CBD also need to be inserted if the procedure will take long time. For example, in embolization procedures. So other than that, okay, as usual, okay, you need to optimize the renal function of the patient. You need to optimize the coagulation profile. Okay, HB level need to be at the optimized level. Okay, you need to give some steroid cover, especially if patient is allergic to contrast. Okay, sedation need to be prepared. Okay, and for unstable patient, you might need to discuss with anesthesiology because they might need intubation so that we can do procedure smoothly lah. Okay. And then sometimes the referring team also forget about the patient complaint about pain. Okay. Because sometimes when patient come to, when we want to do procedure on the patient sometimes cannot even lie supine because they complain of pain. So to settle this, sometimes it take a long time, sedation and so on. So you might need to consider that before sending the patient to the department. Okay. So these are some of the procedures, okay, that we do. Okay. Diagnostic procedure, for example, angiography and immunography. We also do angioplasty and stenting. Okay, we do aspiration, biliary procedures, biopsy, drainages, and so on. Okay. Okay. These are the example, okay, of some of our works or daily work. Okay. This is an example of a central venogram. Okay. So usually we do this on patient that need central catheters. Okay, so usually we do this to check the central venous system. Okay. Okay, another example. This one is PICC, peripherally inserted central catheter. Okay, we use it for like if patient need like long-term infusion or maybe, for example, to administer drugs and so on. This is a chemo part. Okay, as the name goes, it is used to give chemo drug on patient in cancer patient, for example. This is a tunnel permanent catheter, okay, for dialysis patient. Okay. Sometimes they are waiting for the fistula to mature, So they might need to have this for their dialysis, okay, before they can use the fistula. This is a case of mediastinal tumor, which is causing the SVC obstruction. Okay, so what we did was we did balloon angioplasty, okay, and then we put stent, okay, to maintain the patency of the SVC. This is IVC filter. Usually we do if patient have like some tumor or some high risk of um, um, high risk of pulmonary embolism. Okay. So this one is to track the blood clot, not so that it won't goes to the pulmonary artery. This is a case of this transarterial chemoembolization of hepatocellular carcinoma. Okay, on the image on the left side, it shows how we deliver the chemo drug. Okay, we will deliver it using a small catheter. Okay, and then the image on the right side is after we have give the chemoembolization drug. Okay, and you can see all the chemo drug is accumulating in the hepatocellular carcinoma. Okay, so all the drug is being mixed with some lipiodol, which appears darkish in color in this image. This is a case of bleeding duodenal ulcer. Okay, so patient was referred as urgent because the HP is dropping very fast. Okay. So when we did CT, we found out patient to have active bleed from the duodenum. Okay. So this one we did angiography. Okay. And then we found the bleeder, and then we proceed with embolization. Okay. So we put coils to the pancreatoduodenal artery, okay, and then to stop the bleed. Okay. Another one. Okay, this patient is a young patient. Okay, 21 years old. Okay, she was diagnosed with Crohn's disease, okay, inflammatory bowel disease, and then was referred to us because her HP is dropping. We did CT and we found patient to have active bleed from the branches of right colic artery, supplying the ascending colon. So we did angiography, okay, and then we found the bleeders, and then we put coil. Okay, this one is before the procedure, and this one is after the procedure. Okay. And then you can see this one is the bleeder, and then we proceed with coil. We put coil, okay, and then we stop the bleeding. And this image you can no longer see the bleed. Okay. This is a diagnostic cerebral angiogram. Okay. Patient was referred from emergency department, okay, because of low GCS. When we did CT, we found a large bleed in the right side of on the left side of the brain. Okay, and then the case we proceed with diagnostic cerebral angiogram. Okay, and then we found there is a quite large left frontal intravenous malformation. Okay. So this is the cause of the bleed. Okay, and this patient, I'm not sure. Okay, the patient could either be like do neurointervention procedure, or sometimes the surgeon might go in. Another case, okay. If you see this angiogram here, you can see there is a severe stenosis of the superficial femoral artery, okay, here. And then we proceed with balloon angioplasty, okay. And then after balloon angioplasty, okay, we managed to reconstitute the stenosis. Okay. You can see stenosis have dissolve. Another one, okay. This patient was diagnosed to have mycotic aneurysm of the branches of the popliteal artery of the lower limb. Okay, and then we proceed with angiography. Okay, we found the aneurysm, and then we put coil. Okay, you can see here. This one is the coil. Okay, to start to occlude the aneurysm, and this one is post procedure. Okay, the aneurysm is already occluded. Another example, okay, this patient got hemangioma at the foot region. Okay, so we use ultrasound and we puncture the hemangioma, and then we administer drug, bleomycin, okay, to um, thrombose the hemangioma. Um, this one is a case of pancreatic head tumor, okay, and it is causing CBD obstruction. Okay, okay, so as you can see, okay, this one is the CBD, okay, and the contrast is not flowing into the bowel, so there is tumor here, okay, which is causing CBD obstruction. So what we did was we put a PTDD, we puncture the liver, and we cannulate the intrahepatic duct and put a tube to drain the bile, okay, outside. This image is taken during our nephrostomy. Okay. So this is how we do a nephrostomy. Okay. Patient got some stenosis at the distal ureter. Okay. So this one we tried to um, pass the wire, okay, through the stenosis, and then we manage it. So later on, okay, we either put a nephrostomy tube, or sometimes we might even proceed with put integrate stenting of the ureter. Okay. The example, okay, the image on the right side, okay, is a CT guided biopsy um, of the lung mass, okay, on the left side. Okay. So you see, using CT under CT guidance, okay, we introduce a biopsy needle, okay, into the core of the lung mass. So we take biopsy, and the image on the right side, okay, this is the biopsy of iliac bone tumor, okay, again under CT guidance. And the last example is a simple procedure, which is drainage of the ascites. So this is the wire that we put before we put in the pigtail catheter. Okay, that are some of our daily works. Okay, so now we go to statistics. Okay, so this data is being taken from the year of 2019 until 2021. Okay, as you can see, in 2019, we did about just over 150 cases, and then COVID struck us. Okay, the number of cases in suspect reduced drastically, sorry. And in 2020, okay, despite reduced number of cases, okay, the IR case that we do still increases. Okay, so now there is about, I can say about 170 to 175 cases in 2020. And as we recover in 2021, you can see spike of IR case. Okay, last year we did over 350 cases. So more and more people are recognizing IR as a very important branch of a clinical branch. Okay, so as you can see, we also have like spike in cases. Okay, so more and more cases are being referred to us. Okay, so and inshallah in future, okay, the number of cases will increase more. So our future endeavors, okay, our aim for the future, okay, we want to establish a proper IR unit in SASMAC, okay, and then we want to start IR clinic in the future. Okay, very important because for some patients that might need consultation and explain them what the procedure is all about. So we like call them to the clinic and explain all to them. Okay, and also we sometimes we need to see them first to see what kind of procedure is suitable for them. Okay, another branch of interventional radiology, which is neurointervention. Okay, we want to provide service for neurointervention in the future. Okay, and the last one is to make SASMAC as IR training center, because currently the number of practicing IR, okay, especially in government sector, is not a lot. Okay. The demand is there, so we need to produce more IR in the future. So if SASMAC can become IR training center, so it will be very, very good, especially for the east coast of the Asia. Okay. So what are our limitation? Okay. Of course, manpower. We only have one IR currently, okay, and the cases are increasing so much. So sometimes it's quite hard to take to settle. We also lack of trained support staff, okay, because to do international procedure, to handle the angiography, to handle the um, angiography machine, okay, the fluoroscopy machine, we need trained radiographers. Okay, so they need to be well versed about the machine, okay, the patient position and so on. So they need training. Nurses also need training because in IR we use a lot of catheters, wires, and so on. So the nurse need to go for training to know all of these equipment and how we do the procedure so that they can assist us better. Okay. So of course, I think every place have this constraint, which is resource and budget. For example, to get consumable, some of consumable used for interventional radiology is very expensive. For example, the stands, the balloons, and then equipments. Maybe in future, if we have more cases, we might need more NGO suits. Or as for now, we only have one NGO suit. Okay, and other equipment, for example, the equipment for biopsy and so on, that we might need more. Okay. And of course, to train the IR and also to train this support staff, okay, we also need a budget. Okay. So I think that's it for my presentation for today. So if there is any question, you can ask me.
Okay, thank you so much, Doctor, for your interesting talk. So we open the floor for Q&A sessions. If you guys have any question, can type in the chat box or can unmute. So Dr. Rajiv, there's one question from Dr. Yakin. Assalamualaikum, Dr. Rajiv. Any experience on uterine artery embolization for uterine fibroid? Is it feasible in our center?
Okay. In SASMAC, we don't have any uterine artery embolization for uterine fibroid. Okay, but then in other centers, okay, we do IR do this examination. Okay. Feasibility, I think, is possible to do. Okay, and of course, we need to discuss with our IR. But then I think it's possible.
Oh, by the way, Dr. Rajiv, if anyone or MO nak consult or ask opinion regarding IR, can directly call apa ni radiologi ke macam mana, Doktor?
Okay. I think better for you to come to our department. okay, because every day beside Prof. Radali as the consultant, okay, we also have like the general radiology in charge of international procedure lah. If you go and see the MO don't cannot give you a good answer, then they will come and see us lah, so we can discuss the case. Because I think it's better for you to come directly to us, because sometimes we might need to know some detailed clinical information about the patient. Sometimes we might need to discuss the imaging finding and your clinical finding, and all that will like give us a better idea about the patient, and then after that we can suggest you what is the most appropriate procedure for the patient.
Okay, Doctor, one question. Any role of IR in massive PE?
Yes, I know some center that do like aspiration of the clot of the pulmonary artery embolism. Okay. But again, okay, to do it, we need a special catheter, okay, which is quite expensive. Okay. That one also need to be considered lah. I think we can do using a normal catheter, but then the result won't be as good lah. Yeah. Again, we have to see the case, what the agency, and have to discuss with our IR.
Okay, Doctor, there one question from Prof. Dr. Zalina. Why embolization for uterine fibroid is not available here?
I'm not sure, but then usually all the case will be discussed with Prof. Radani. I think if you guys there's case, like suitable case, maybe like can come and see him and discuss with him. Because I think embolism, embolization, we don't use like some special equipment or so. What we just use like normal pulse and so on. Okay. So I think it's feasible lah. But then again, you need to ask for already.
Okay. So if there is no question, once again, I would like to thank you to our speaker, Dr. Raji, for introducing this talk. I would like to remind the participant as well to register the attendance in I attend, and for medical practitioner to fill in the Google form through link given. And we will end our CME today with Tasbih Kifara and Surah to us. All right, thank you so much, everyone. And thank you so much to Dr. Rajiv again.
Thank you.